So rectal cancer is a bit separate from colon cancer in terms of how we manage it. I mean, if you want to think about where the rectum lies, the rectum is a fixed structure, lies in a very tight space, a lot of nerves and blood vessels and muscles and bones in a very tight space. And unlike colon cancer, rectal cancer has a propensity to come back locally following surgery. And so radiation becomes a very important component of how we treat rectal cancer. Now, studies looking at giving radiation before or after surgery have not shown a difference in survival between the two, but the difference in terms of giving radiation before surgery versus after surgery was primarily with cutting down on the risk of local recurrence and cutting down on the risk of having the need for an ostomy, which is a quality of life issue. So for all these purposes, for patients with rectal cancer, we do treat them with radiation and chemotherapy prior to surgery. That's a standard. And then for more and more patients now, we're moving the chemotherapy that we typically give adjuvantly after surgery into the preoperative setting. So chemotherapy followed by chemotherapy and radiation. And we call this the total neoadjuvant therapy, meaning all therapies are administered before surgery. The patient goes to surgery and then they're done. And that certainly controls the local, improves the outcomes with systemic recurrence, improves survival, local recurrence rates, as well as the need for an ostomy. We continue to struggle with whether we have patients who do not need surgery. We think there's a group of patients with rectal cancer that respond really well to chemotherapy and radiation and chemotherapy prior to surgery and may not even need surgery because of their low risk of local and systemic recurrence. The problem today is we don't have a clear path about who those patients are, or a number of studies are actually looking at how to best identify those patients. Those are the patients that are essentially in the lowest part of the rectum, so the low-lying rectal tumors. Those are the patients that are essentially will end up with an ostomy, which is a quality of life issue when they have the rest of their lives to live. More importantly, some of the studies suggested that, and depending on what study you look at, it's an average of 10, maybe one could think you could reach up to 20% with the right concoction of treatments of patients who will have a clinical complete response. And then perhaps, which is a composite of the tumor actually shrivels to nothing, and then at the same time, so when you put an endoscopic ultrasound, you don't see evidence of it, and biopsies confirm pathologic complete response, or at least pathologically no evidence of tumor, because the only way you can confirm pathologic complete response is if you do the surgery. When a study looked at applying a watch and wait strategy, they found that a small percent of patients, about 10%, never actually had their cancer come back. Now, these numbers were difficult to reproduce across other studies. So at this point of time, I frankly don't think there's a clear path for us in the clinic to decide who doesn't and who does get surgery. Although, again, one can argue there may not be a significant risk for some of these patients who decide, I don't want to have that surgery. Can we just watch and wait, especially for the lower lying tumor with a clinical complete response? That discussion can happen in the clinic. And if the patient understands the risks and the physician understands the literature surrounding that, then I think it's okay for some of these patients. But for the overwhelming majority of patients, surgery after chemotherapy and radiation will remain the standard. The Nordic group looked at essentially taking our typical 5.5 weeks of chemotherapy and radiation and bringing it to 5 times 5, what we call the 5 times 5. So shortened course, high dose radiation. The experience, at least from the Nordic trial, is that it historically provides outcomes that are very similar to what we expect with standard chemotherapy and radiation. That has been confirmed in smaller studies, including in the US, although there was one study that suggested that we may lose some local control by applying the 5x5 versus the full chemotherapy and radiation. At our institution, um, all patients who are early stage or have early stage rectal cancer, those are the patients who will have 5.5 weeks of chemotherapy and radiation. The only time we apply the 5x5, if one, the patient desires or refuses to get the full blown, but two, more importantly, for those patients with limited metastatic disease, where local control remains desirable, because the patient has a single or a couple of lung lesions or liver lesions that are resectable, and then you want to ensure that the patient's local control is optimized. In that group of patients, actually, we favor the 5x5 because the intent is different in this case. So for the stage 4 limited disease where local control is desirable, 5x5. For the earlier stage patients, we still apply the 5.5 weeks. Now, keep in mind that for stage 4 rectal cancer, 95+% of the patients will never require radiation. We're talking about a very small subgroup of patients who may have just very limited disease and where you can get them into remission and then local control becomes desirable. So that's very important. I don't want everyone to think that we should give radiation to every patient with rectal cancer as a stage 4 rectal cancer, and that's important to keep in mind. Only very select few, and this is where you go with the 5x5.